Hello, good evening. Nandito ulit tayo, Dude Sorda, sa Bisda ko. Tuloy natin yung nasimulan na alamin, kilalanin kung ano ang ibig sabihin kung anong o bakit may heart failure or ano ibig sabihin ng failure, ano yung mga symptoms niya at ang komplikasyon. So, by the way, bago tayo magsimula, welcome to Bisda ko. And for those new, don't forget to like, subscribe. And yun, nasimulan na natin ng part 1 at doon na explain kung ano ang mga tipo ng heart failure. So mayroong systolic heart failure, diastolic heart failure, and it is more on the left ventricle, okay, ng puso. So heart failure, kung sa atin tatawagin, mahina ang puso. So yun, na-explain doon, just see the part 1 of this live presentation. Actually, shout out to Ninja Nerd. He's a professor, a YouTuber. Siya, ang ganda ng pagka-explain ng pathophysiology na tinatawag kung paano nagkaroon ng heart failure ang isang tao. And this part 2, yung part 2, na-discuss doon yung mga maaring symptoms, okay? At nabanggit na doon yung edema, yung shortness of breath, yung tinatawag na dyspnea, at kung bakit, doon makikita ninyo sa part 2. Just click the link below sa description. And today, sa part 3, i-continue yung napanood natin na video and he will be discussing on the complications. Ano ang mga komplikasyon having this type of syndrome, heart condition. So, by the way, if you would like to watch the full video of Ninja Nerd, see the description below. Nandoon lang yung kanyang description. Nilagay ko sa description below. Just see it. Nandoon yung full video of Ninja Nerd channel. He's a professor, by the way. So, maano lang, very simple and concise illustrations, and then using a very terms, although nandoon din yung mga medical terms, pero for a simple person like me, having this dilated cardiomyopathy, so as a patient having a heart failure, I could easily understand. So that's why I'm sharing also this to you para naman it's better to have informations, okay? We may not have an in-depth kasi hindi naman tayo mga medical students or doctors, but for medical students, malaking bagay, para sa akin, I could say. But I am explaining here or sharing here on the patient perspective as a patient. Kaya sige, sabay tayong panoorin. And I just would like you to know na mag-stop ako once in a while, okay? Para hindi tayo ma-copyright. Although, of course, I'll give the credit to the YouTuber Ninja Nerd for this. Okay, sige. Tuloy tayo. So, by the way, again, ulitin ko lang, on the part 2, inano niya yung yung symptoms ng having an high output heart failure. Kasi doon, makikita ninyo doon kung paano magkaroon ito dahil this is particular, okay? Particular bakit? Kasi mostly the failure is left, okay? And output is low, as explained. While in this will be a particular na magkaroon ng high output. So, pag magkaroon ng high output, relative doon sa blood pressure. So tataas din ang blood pressure. Pag tumataas ang blood pressure, magkaroon ng problema, sabi niya. Dahil yung tinatawag na systemic, ventricular resistance ay as in mapunta din yung kidney, maapektuhan ng kidney. So, yan ang isa daw sa maging cause na manlalamig yung lalo na dito sa paa. Okay? Or mag-change ng color. Okay. So, naano din niya yung as a left heart failure complications na nakikita ninyo dun sa pulmonary congestion. So, na-explain niya yun bakit mayroon tinatawag na shortness of breath na the patient lying down mas worse or kahit hindi mag-lying down, mayroong shortness of breath dahil doon sa congestion sa pulmon. Okay? Bakit magkaroon ng congestion, as explained, yung sa dugo, imbis na ilalabas kasi ang heart failure, ang ibig sabihin nun, may problema sa pumping ng dugo, yung pagbuga. So, instead na ibugan niya completely, maipon lang doon. So, once na maipon, ma-spilled out dito sa lungs. Okay. So, sa ngayon, ituloy natin yung sa left heart failure complications na tinatawag na cardiogenic shock. Okay? Kung anong ibig sabihin na to, sabay natin panoorin.
Trigger here that can happen is an MI, a massive arrhythmia, or you stop taking your medications. These are very, very common triggers. Now, again, same concept. The patient has a massive drop in their cardiac output. If you drop their cardiac output, you're not going to be getting a blood flow out of their heart. When you don't get enough blood flow out of the heart, particularly enough volume, you drop that out, what happens to their perfusion? Oh, that's stinky. That systemic perfusion goes down. So not only whenever you have a low cardiac output, do you have a hard time getting blood out of the heart and it backs up into the lungs, but you have a hard time getting it out of the heart and delivering it to multiple tissues. When you have a decrease in systemic perfusion, the problem with this is that your body kind of says, okay, perfusion's kind of stinky right now. That's because the cardiac output's really low. You know what the body tries to do is it says, okay, what I'm going to do is, if the cardiac output's low, what's that formula? BP is equal to cardiac output times the systemic vascular resistance. Let's write that out. So BP is equal to cardiac output times the systemic vascular resistance. In patients who are in cardiogenic shock, this is low, causing this to be low. What has to compensate, my friends? SVR, and this will shoot through the roof. And when SVR goes up, it clamps down on your vessels, squeezes them. And now you have very little blood flow going to your extremities. You know what this is going to do? This is going to cause these patients to have very cold or pale extremities. Another really, really terrifying sign here is they have like mottling. And this is really, really kind of scary. It's where they have this weird kind of discoloration, usually at the knees. It's a very it's a very poor sign of perfusion. And this is usually because you're clamping down on those vessels to compensate. Another thing is that when you decrease systemic perfusion, not only do you create this reflexive vasoconstriction, you also get organ malperfusion, right? If I have organ malperfusion, oh man, that ain't good, because now I'm not perfusing various tissues. What are some of these tissues that actually become affected because of an increase in more organ malperfusion? One is the brain. The brain is super sensitive to blood pressure. The coronary circulation, which supplies the myocardium of the heart, well, it's going to make things a lot worse. It becomes very susceptible. The kidneys become susceptible. And the GIT would probably be the last one of the line, but it's also super susceptible. If I don't perfuse the actual brain, then I can develop encephalopathy. And this is probably going to be one of the most common causes. Sometimes, if it's possible it could cause the TIA/CVA. All right? So that's another thing you want to watch out for. The other thing is that if you don't perfuse the actual myocardium, it may
Okay. Uh, Sorry to interrupt that. So isa na narinig ninyo yung pinakaimportante to minimize the symptoms is to maintain the medicines. Okay, na huwag kalimutan. Yun ang mga na ano niya doon eh. Kasi otherwise, it would complicate things. Okay? So, may mga perfusions yung mga pinagsasabi dahil nga doon sa cardiac output. Okay? Cardiac output which is related to BP, blood pressure, and the systemic vascular resistance. Kung ano yon, review nyo na lang. Sabay din natin i-review yan later. Sige, continue tayo.
The other thing is it may stimulate, son of a gun, it may injury to the kidneys. This is called an AKI. There is a very common terminology that you may hear here. When patients have very severe heart failure and they don't perfuse their kidneys very well because of decreased systemic perfusion, but high, so it's hard to get blood out of the kidney, they can develop something called cardiorenal syndrome, very common trigger of AKI, so don't forget that one. And the last one is they may cause acute mesenteric ischemia. This is another really, really big one, or ischemic colitis. And this is another big trigger, so you're going to want to watch out for any kind of like bowel ischemia and abdominal pain. The last thing that's always a feature of systemic perfusion that's being very, very poor is your tissues. Whenever there's very little oxygen that's being delivered to the tissues, so here the tissue is supposed to be getting oxygen. If it's getting very, very little oxygen, they do not like that. And what they do is they trigger the production of a molecule that's usually a sign of poor perfusion. You guys know what that's called? Lactic acid. But lactic acid gets broken down into lactate. And so you want to watch out for this because one of the things that this will do is this will really cause the pH to drop and it'll trigger an acidosis. So watch out for acidoses that can occur in a setting of cardiogenic shock. So again, when a patient has heart failure, it can kind of look a little bit different. The patient may have chronic CHF where their primary symptom may be dyspnea, paroxysmal nocturnal dyspnea, or orthopnea. But if they develop acute decompensated heart failure from those triggers, MI, tachyarrhythmias, medication noncompliance, they can develop severe pulmonary edema, hypoxia, respiratory distress. And most patients who have chronic CHF, they may just have minimal decreased systemic perfusion. And the way that they compensate is an increase in systemic vascular resistance. So they may have cold, kind of pale mottled extremities. But whenever it's really bad, to where there's an acute decompensated heart failure due to an MI, tachyarrhythmias, medication noncompliance, now they don't perfuse multiple organs. And they can develop things like encephalopathy, MI, AKI, and mesenteric ischemia, and lactic acidosis. These are big things to think about. All right, we come to the last one here. Patient has right heart failure. Okay. So the patient has right heart failure was because it's something wrong with contractility or the high afterload, pulmonary hypertension. This one's
Okay, so yun pala yung cardiogenic shock tinatawag. So talagang complications dahil pati kidney, yung mga tissues, dahil sa tinatawag na yung perfusion is maging mababa. Kaya ayun. So komplikasyon nga. And now ngayon, i-tuloy niya yung understand natin better, sabay natin tanungin.
so easy. Whenever the right heart is damaged, what happens is, again, the concept here is that it's either you can't fill it or you can't get blood out of it, right? So that's either one of those concepts. You can get blood in or you can't get blood out of it.
Il mio capo mi ha detto torna in ufficio o sei gli ho risposto licenziato.
Okay, sorry na-interrupt natin. Meron lang kasing matalas na. So, yun ang I know na hindi ganun kadali maintindihan, but to make it simple, it's not that easy kasi having a heart failure is no cure at the end, as we have listened. Okay, kung di palala siya ng palala. The only thing is that ma-minimize lang ang symptoms, hindi masyadong lalabas yung symptoms through medications, proper medications, huwag kalimutan ng medications. Yun lang. So far na nakita ko yung at also based on my experience na talagang regular consultation or regular monitoring with the cardiologist regarding the status. Okay? Mapa-left heart failure or mapa-right heart failure. But again, hayaan ko lang din muna siya mag-advertisement sa kanyang channel. Ano? So, mostly, as a review, it starts with the left ventricle heart failure. So, dahil yung contractility. Contractility meaning yung capacity to push. Okay? Dahil dilated. Okay? And one of the causes nila bakit is dilated cardiomyopathy. Meron siyang tatlong pinag-binanggit. Mas interesado lang ako sa dilated cardiomyopathy kasi that's my case. And later on, dahan-dahan, is mapunta na siya sa right. Tawag naman na right ventricle heart failure. Yun naman doon is, pag sa right, ang ano naman doon is the feeling. Okay? Feeling, ibig naman sabihin noon is mas mahirapan naman siyang mag-feel yung tawag itong magpasok. Okay? So, ayun. Kaya nagkaroon siya ng mga complications katulad ng na-discuss. Sige, tuloy natin.
Happens is pressure in the right heart increases. And we use a terminology to really describe that, and that's called your central venous pressure. So your central venous pressure becomes very high. When your central venous pressure is high, what happens is the blood is kind of a measure of the backing up into your superior vena cava and blood backing up into your inferior vena cava. And what this will do is this will kind of present in two different ways that you want to try to look for. One is it'll present with a patient having a lot of jugular venous distension. So they'll have a plump jugular vein. And the other one, they'll have edema or lower extremities, usually what's called pitting edema. So when you press on it, it kind of really dips in and gives this kind of deformity there. This is super common in right heart failure. Another common presentation, again, regardless of the type, whether it's a problem filling or problem getting out, the concept is the same, is that you have a very high central venous pressure. When your central venous pressure is high, the blood is going to back up into the inferior vena cava. And what it does is it causes one particular problem, which it leads to hepatic congestion. So you know the liver, I'm kind of zooming in on a basic model of the liver. Let's say this is a liver cell. This is an artery. This is the hepatic veins, which
Ayun, another ng complications punta na naman doon sa liver. So, kanina discuss niya yung kidney, the tissues, and then ngayon naman is dito sa liver kung ano ang maging komplikasyon.
into the IVC, and this is a biliary duct. Whenever this hepatic vein is congested and it can't get blood to go up, it congests in the liver. and causes the liver to become injured and damaged. And you know what this could potentially present as? This could cause a patient to develop liver failure. More specifically, I would say you see this more commonly as a cirrhotic kind of presentation, but you can see this as a potential trigger of liver failure because of the increased hepatic congestion. All right. The other thing that it can do is it can increase your portal pressure. So what happens is your hepatic veins, what happens is it can actually cause this to really cause the portal pressure within the venous circulation, the hepatic portal circulation to become very, very high. So if you increase your portal pressure, what this does is this causes the hydrostatic pressure in the portal veins and the peritoneal capillaries to be super high and leak fluid into the abdomen. And when you leak this fluid into the abdomen, what do we call this type of fluid that leaks into the abdomen? And so that's another very, very common presentation here is ascites. So watch out if a patient develops liver failure and they have a history of right heart failure, think about that. If they have ascites and they have a history of right heart failure, think about that. And again, if they have very plump jugular veins and pitting edema, think about a right heart failure. And the last one, it's not commonly thought of, but it can happen. Left heart failure talked about cardiogenic shock. Right heart failure can also get cardiogenic shock. So think about this. This concept is super interesting. In this situation here, you're having, let's say, blood difficulty. This is more common in the systolic types, where the right ventricle is super dilated. In this situation, you have problem getting blood out of the right heart. And because of that, now this right ventricle has a hard time. If it becomes super dilated, maybe it can't fill properly or it just can't get blood out of the heart. When that happens, because you can't get blood out of the heart, the right ventricle dilates even more. So if it's dilated before, it dilates more. All right? So now this sucker is huge. So whenever this happens, you can't get blood out of the heart, it's going to stimulate the right ventricle to dilate even more. When the right ventricle dilates more, the next thing it does is it causes the septum to bow over into the left ventricle. And now the space of the left ventricle, it's smaller. So then it causes, it's called a septal shift. So a septal shift. We'll say that this septal shift is occurring from right to left, from the right side to the left side. What that does is it makes it hard for the left ventricle to fill with blood because now it's much smaller. If it can't fill with blood, what happens to the left ventricular cardiac output? It drops. So now you have a septal shift, and that's going to cause a decrease in the left ventricular filling. If you decrease the left ventricular filling, that is going to then do what? That is going to decrease the left ventricular cardiac output. And if you decrease the left ventricular cardiac output, oh, son of a gun, that potentially lead to systemic malperfusion. And then if we go on further, cardiogenic shock. So this is a pretty scary one. I'm actually usually often heart failure causing cardiogenic shock, but when you do, it's pretty terrifying because it's a really bad one. But this is another potential one that I want you to think about, but you really primarily only see this one with right ventricular MI as the particular etiology here, not so much the pulmonary hypertension causes. All right, my friends, that covers the issues or complications, if you will, of heart failure. It's a pretty disastrous thing if it gets really, really bad. What I want to do now is I want to take you through how to diagnose heart failure. First thing is get a chest x-ray. This will help you. If they have cardiomegaly, that's somewhat helpful.
Okay, so now tuloy tayong paano naman though this is we're not doctors. This video, there's no claim in this video na ginagawa ko na makakabuti. What I mean is kailangan nating magpakonsulta ng doktor. That's what I'm going to tell you. So here, because as a professor, siya sinishare niya kung probably what are the typical tests or mga laboratory tests na gagawin para diagnose ito. But, cardiologist knows better than us. But, panoorin pa rin natin for information purposes.
Do they have effusions, pulmonary edema, and curly V lines? That's all suggestive of left heart failure. Now, that being said, if a patient has these findings, that doesn't define or determine that they have heart failure. I want to combine, pulmonary edema, pleural effusions, is their left heart doing a good job?
Sorry, against lang natin dahil so, pinakita niya ngayon what are those umubusan tayo ng battery. Natin, sorry. Oh, by the way, lang. I-balik lang natin.
Cardiologically, pleural effusions, all suggest of left heart failure. Now, that being said, if a patient has these define or determine that they have heart failure, I want to combine pulmonary pleural effusions, their heart doing a good job. Their heart is doing a job in peace. It's not just use quickly exclude a CHF exacerbation. Then you can say, okay, they're disqualified not from observation. It's really high, you can't test. This rejection fraction is it percent electrical doesn't move all the heart failure. In combination with chest, very good. Also do exam. If you don't see on the chest, look at the JVD, look at the legs, look at the abdomen to look to see if they have any features of systemic congestion, and combine that with their echo. After you've done that, you should be able to determine, is it right versus left? That's pretty straightforward. Now, the most definitively diagnostic test to determine if the patient is in acute left heart failure or in left heart failure in general is to do a right heart catheterization, also referred to as a Swan-Ganz catheter. You take a catheter, you run it down the IJ, run it into the pulmonary, into the right atrium, into the artery, and up into these like pulmonary artery capillary area. Inflate the balloon and measure the pressures. I told you that the pulmonary capillary wedge pressure, if it's really high, it's very suggestive of a failure of the left heart. And if it's greater than 18 millimeters of mercury, that's a very suggestive number of left heart failure. So if a patient has elevated BNP levels, an echo, and a pulmonary capillary wedge pressure greater than 18 in combination with a chest X-ray suggestive of pulmonary edema, I can really be confident in them having left heart failure. Now, with that being said, if it's acute left heart failure, it's important to go through their medication list, look to see what their heart rate is, and look to see if they have any valvular disturbances. But one of the big ones that I have to do is get an EKG and also consider heart cath if I think they're having an MI. Because it's going to find the occlusion and treat that, and that might be the thing that knocks them out of this acute heart failure. All right, how do we rate heart? This is really, really important.
Okay, start ko lang diyan na part, yung catheterization, okay? So, of course, on my experience, yung cardiogram ginawa din kaya identify ang, problema ko sa left ventricle at saka then lately last September part of the process yung, catheterization, okay? Medyo mahirap, ano parang nabubulol tayo 'no, but anyway, so may tinutusok sa liig para malaman kung to what extent yung, status. So yan yung, nagsasabi of course all this will be, advised by your cardiologist. Hindi ibig sabihin na tayo lang mag-isa magpunta doon at sabihin natin na, "Uy puwede ako magpaganito, puwede." No, no. A cardiologist under cardiologist advice. Okay, so of course let us always consult doctors kung papaano. So next, narinig niyo naman yun, i-discuss na niya ang, tawag na paano yung part na sandali ha, medyo nawala lang ako. So, I think papaano anyway, let's try together.
As to determine if the patient is an acute left heart failure and left heart failure in general is to do a right heart catheterization, also referred to as a Swan-Ganz catheter. You take you run it down the IJ, you run it into the pulmonary, into the right atrium, into the pulmonary artery, and up into these pulmonary artery capillary areas. Inflate the balloon and then measure the pressures. I told you that the pulmonary capillary wedge pressure, if it's really high, that's very suggestive of failure in the left heart. And if it's greater than 18 millimeters of mercury, that's very suggestive of left heart failure. So if a patient has echo, pulmonary capillary with a chest X-ray suggestive of pulmonary edema, I can really be confident in them having left heart failure. Now, with that, if a patient has acute left heart failure, it's important to go through their medication list and look to see what their heart rate is and look to see if they have any valvular disturbances. One of the big ones that I have to do in EKG and also consider a left heart cath. I think they're having an MI because that's going to find the occlusion and then treat that. And that might be the thing that knocks them out of this acute heart failure potentially. All right, how do we treat heart failure? This is a really, really important topic. When I treat them, I specifically went into this for a reason. I want to reduce sympathetic nervous system activity, reduce RAS activity. And if you remember, increasing AMP activity did what? Decrease RAS. So my goal is to decrease sympathetic, decrease sympathetic, and decrease RAS. How do I do that? If I decrease my sympathetic nervous system, I have to use like beta blockers and SGLT2 inhibitors. So metoprolol or empagliflozin. Usually these SGLT2 inhibitors are very, very important in patients with diabetes, but if they have cardiovascular disease, it's also beneficial. And what happens is they reduce the sympathetic nervous system. That reduces the heart rate, and that also reduces the systemic vascular resistance. I don't constrict the veins. I don't constrict the arteries as much. I don't actually cause changes in preload and afterload, and I don't cause ventricular remodeling. That improves ventricular function. That's mortality beneficial right there. The other thing is that SGLT2 inhibitors also cause aquuresis. They cause you to pee out tons of water. And so that can help with a lot of the edema if the patient is edematous. The next concept is I want to reduce RAS activity. So the reason why is whenever I have low cardiac output, again, we said increased sympathetic and low cardiac output activate renin. So renin leads to eventually angiotensin 2. But if I give them a drug called an ACE inhibitor that blocks angiotensin 1 from being converted into angiotensin 2, if I also give them a drug like an ARNI that increases AMP, it prevents AMP from being degraded. If AMP builds up, it shuts down angiotensin 2.
Okay, so diniscuss na niya ngayon yung treatment, no? So, the medications. Nabanggit niya doon yung beta blockers, mga ano ba yun, ARNI, or receptors. Anyway, those are terms na cardiologist na we don't need to dig on that. Okay. Ang may ano ko lang is my experience. Ito yung mga medications na binigay sa So kung what are these, I don't want to say it, yung mga brand, whatsoever. Next lang tayo, like yung beta blockers, then meron tayong diuretic, kasi kung paano iwas na ma- yung fluid o red para mailabas. And yung mga ACE inhibitors or mga iron inhibitors, medyo marami. Okay, and yeah, three, five, eight, nine, eight, I think eight Medicaid, eight medicines. Okay, well, aside para sa aking other, like what I've said, yung osteoporosis, yung vitamins mo, yung vitamin D sa calcium, and then the hypothyroidism. So, sa hypothyroidism, but more, since this is discussed more on the heart failure, so yan yung mga treatment na kailangan maging religious, maging faithful, na hindi dapat ma- mag-skip or maging irregular. It should be regular treatment ng medicines. Okay. So, ayun, it's not that easy as a patient perspective. Kaya I am preparing. That's why para sa akin din naman this information is very helpful to understand better sa aking present situation. Para naman hindi, so, here is there, side is there, but understanding it, bakit ganito yung feeling ko, bakit ganun, bakit ganun. So, at least in here, medyo nasagot yung aking mga bakit. Okay? And for those who have this condition like me, the heart condition like me, ang akit lang, sabi ko, let us not lose hope. Okay? I know that it's pati ako. Okay? And that is medyo first, yes, the help the family, the people around you, family, number one, the family. So I would like to thank this opportunity bago tayo to thank my wife, my son, sa kanilang support. And I am praying they will be given more strength. Okay. Even me, guidance to understand where and condition. I believe science. Okay. Of course, I believe I have faith in God and science. Okay. So, mga bago na yung kanilang mga treatment ngayon, may mga bagong technologies. So, hindi na ganun ka, kahirap. Okay. The only thing is that isa lang sa mga big concern, especially sa other countries, na talagang very expensive ang treatment ng heart, having heart failure. It's expensive. Okay? So, sa gamot pa lang, then the regular consultation sa mga doctors, expensive. And again, I am thankful na nandito ako sa Italy. We are in Italy. Ang kanilang health system is not totally free. It's what I could say it's free. Right now, what I am doing, kasi nga, punta na ako sa heart transplant. Okay? So, talagang wala nang magawa dun sa aking, of all the medications, of all, kasi may implantable cardio device din. Nilagyan ako ng pacemaker with defibrillator, hoping, that was 2 years ago, hoping na makatulong. But yes, nakatulong naman to reduce the symptoms. Okay? Pero wala eh. Ganun pa rin. So, heart transplant is the end solution. Sige, tuloy natin.
Also given ARB. ARB blocks angiotensin 2 from binding to receptors. All three of these drugs will help to decrease angiotensin 2. If I decrease angiotensin 2, I reduce the constrictions of the arteries and the veins, and I reduce ventricular remodeling and a mortality benefit. Another thing is angiotensin 2, if there's less of it, there's less aldosterone and also ADH, but particularly aldosterone, because now there's less sodium and water retention. If I don't retain much sodium and water, I don't have as much edema, but I also don't have as much preload, and I don't cause ventricular remodeling. That's aldosterone antagonists would be really, really beneficial in shutting down aldosterone production. This is the concept, and these are the that we have to incorporate patients who have heart failure because they have mortality-reducing benefits. Okay, that's a part of our guideline-directed medical therapy. Other things that we can add on with guideline-directed medical therapy is alternatives. So if the patient's African American, they can't tolerate an ACE inhibitor and ARB, hydralazine and isosorbide dinitrate is a good combo to add because they're good vasodilators. The other one is an alternative to a beta blocker. If they're maxed on a beta blocker and they are in normal sinus rhythm, ivabradine can be considered. If you want to help them to get rid of a lot of the sodium and water retention, you can make them pee it out by giving them diuretics, loop diuretics and thiazide diuretics. And then the next thing is if a patient has the need for device therapy. So what I mean by this is if a patient has heart failure, especially left heart failure.
Okay. So, stop ko lang part na yan. Ayun, now, I understand better kung bakit yung nabanggit niya ngayon, aside from the medications, yung mga nabanggit niyang beta blockers, the ACE, the ARNI, ARN, the aldosterone, at ito yun, kasasabi lang yung device. So that's, ngayon, naintindihan ko na the reason, of course, naintindihan ko before, but it's now more clear to me. Purpose of this ICD, the Implantable Cardio Device. Sige, interesting. Tuloy natin.
Stretches out the left ventricle and kind of causes left bundle branch blocks. And then that alters the synchrony of the ventricles. If I give them what's called a CRT, cardiac synchronization therapy, it'll make sure that the ventricles are contracting kind of in tandem and improve potentially the left ventricular ejection fraction. I should definitely be instituting that in patients with an LVEF less than 35% and an LBB. All right, that's a CRT.
Okay, yun yung CRT, the Cardio Resynchronization Therapy. Ayun, kasi yung akin, I have the tinatawag na LVHF, left ventricle heart failure, which has an ejection fraction of less than 25%. So, narinig natin na having this device, malaking tulong para ma-resynchronize, okay, yung left at saka right ventricles, mag-synchronize yung kanilang pag-function. So, very big thing.
If the patient has a left ventricular ejection fraction less than 35% and they have ventricular arrhythmias, they need to get an AICD. This will shock them if they go into VTAP or into VFib and prevent them from going to arrest. Is if a patient is on all of these medications, they have device therapy, left ventricular ejection fraction is less than 25%, they're not looking, and they look like they're going to need a transplant, sometimes we will place something called an LVAD, a left ventricular assist device, which will take blood from the left ventricle and shunt it a different direction into the aorta to give that left ventricle some time to rest. Are in cardiogenic shock, all right? Their systemic perfusion stinks. I want to have one primary goal, which is to increase systemic perfusion. So increasing systemic perfusion is very beneficial in patients who are in cardiogenic shock. So what could I do? Inotrope or mechanical circulatory support. One way I can do that is I can give them things like dobutamine or milrinone. These are commonly used in acute decompensated heart failure or cardiogenic shock. The benefit of these is that they reduce afterload and increase contractility, which combined increase cardiac output. The downside is that evidence has shown no reduction in mortality. The other drug is digoxin. This is an oral IV drug, so you can take this outpatient. You can't take these outpatient. This you can give to the patient been shown to increase contractility and decrease AV node conduction. So it's good in atrial fibrillation as well. It is not shown to reduce mortality, but it may reduce the actual hospitalizations. So there's a potential benefit to digoxin and increasing perfusion, especially in patients with cardiogenic shock, and even as an outpatient continuing that drug. If the patient is failing these inotropes and they're continuing to decompensate and show signs of potential failure, then we go to device therapy. And there's two ways that we go. An intra-aortic balloon pump has been shown to at least preserve coronary perfusion. So this sucker deflates during systole to get blood to go forward, and then it actually inflates during diastole. So here during diastole, it inflates, and it keeps the pressure all here in the aorta really high. And what that does is, guess what comes right off of the aorta here? The coronary arteries. So if the pressure is high in the aorta during diastole, it's going to improve coronary perfusion and improve myocardial contractility. That's the benefit of this. Most times, patients who end up on cardiogenic shock refractory to a lot of medications, such as dobutamine, milrinone, intra-aortic balloon pumps may require something called VA ECMO. This is called venal arterial extracorporeal membrane oxygenation. We can run it into one of their veins. We run it out of the vein and into a pump. From there, we run it through an oxygenator, and then we put it in a catheter that runs right into the artery. These are big stinking catheters, and they are designed to be able to help to maintain amount of flow and augment the cardiac output and also oxygenate flow. So this is a potential beneficial therapy that could be used as a patient in refractory cardiogenic shock. The other thing I think is important to remember in a patient who's in cardiogenic shock or having any signs of cardiogenic pulmonary edema is what's called BiPAP. Use diuretics to help to get rid of some of the sodium in water, which will help to reduce some of that actual pulmonary edema, but BiPAP has been shown to potentially increase the intrathoracic pressure. That will help to reduce right ventricular preload. So you don't have as much blood going to the right heart, and you don't have as much blood going out of the right heart. So now less blood is going through the pulmonary circulation and going left heart. If there's less blood going that way, that's going to have less blood leaking out into the pulmonary interstitium, less pulmonary edema. The other concept is it drops your left ventricular afterload. So the pressure in the aorta drops. So it's easier to get blood out of the left ventricle. If blood coming to the left heart, you have more blood going out of the left heart. That's going to improve your cardiac output and reduce pulmonary edema, but more particularly reduce pulmonary edema. And that's one of the benefits of this drug in patients who are in acute heart failure or potentially cardiogenic shock. All right, I know this is a lot. Let's go through this in a systematic approach. A patient comes in, they have heart failure, you've changed their modifiable risk factors. After that, you start them on an ACE inhibitor or an ARB, all right, plus a beta blocker. They're still symptomatic. Give them diuretics to reduce venous congestion, whether it's systemic or pulmonary. They're still symptomatic, add on an antagonist and an SGLT2 inhibitor. They're still symptomatic, and they're potentially unable to tolerate an ACE inhibitor or an ARB. Well, switch them. Switch to an ARNI if possible, so an angiotensin receptor neprilysin inhibitor. So this would be things where you put them on like sacubitril, valsartan. So these are very good drugs that have been shown to be very beneficial. The other thing is if they can't do that one, or if they're African American, consider hydralazine and isosorbate dinitrate. It actually has a mortality benefit. If the patients are symptomatic on all these therapies and rhythm max out on a beta blocker, give them ivabradine. If the patient has a left ventricular ejection less than 30 percent and a left bundle branch block or a QRS greater than 120, give them cardiac resynchronization therapy. If despite all measures they remain symptomatic, try to increase their perfusion. Usually inotropes would be the next step here. So digoxin would probably be the one that you'd want to continue outpatient if they're in overt cardiogenic shock, milrinone or dobutamine. And then from there, if you have to, mechanical circulatory support if they're in overt cardiogenic shock, intra-aortic balloon pumps via ECMO. Hopefully they recover. And then the thing that you would need to put them on to bridge them to a transplant is, and hopefully the cardiac transplant improve. All right, my friends, that covers heart failure. Hope it makes sense. As always, until next time.
On complications, then the treatment, and yung the solution. Okay, so of course I am praying na kayo noon, ano? So, huwag mawalan ng pag-asa lang tayo. And again, let me grab this opportunity again to thank Ninja Nerd Channel. Please subscribe to Ninja Nerd Channel. And also, of course, this live of mine, subscribe to Bizdako. And I would like to grab this opportunity, all of you, my viewers, my subscribers, and also to thank my benefactors because I have a GoFundMe campaign, which you can see the link below. And I am so happy that many people have responded to my campaign, helping me financially in this heart failure journey of mine. Maraming salamat. Salamat kayo. Thank you so much for your financial help. Malaking tulong po sa akin. And of course, your prayers. Okay? Thank you so much also. And it helped my morale. And again, see you next time. Just watch the part 1, the part 2, and this one, the part 3. Okay? So, I hope you have a good evening and happy Sunday.